Good evening, sir. I'll be presenting a case of my patient name Mrs.
Please introduce yourself.
Sir, myself Dr. Nitesh. I'm third year from Sarvagara Hospital. Okay. I'll be presenting a case of Mrs. US, 65-year-old female. She's resident of Rohini, Delhi, married for 40 years, housewife by occupation, and educated up to 12th standard. She was admitted with us on 12th April 23rd and examined by me on 17th 4th 23rd. History was given by patient herself and her son and seems reliable. She presented to us with a complaint of pain abdomen for 10 days and cloudy drain bag fluid for 4 days. I would like to start the history of present illness. 25 years back, when she was approximately 40 years old, when she was diagnosed to have raised blood glucose levels during routine investigations, she could not recall other investigations. No urine or radiological investigations were done. On direct questioning, she told there was no history of excessive thirst, decreased appetite, passing large amount of urine or recurrent UTI or OD of urine. She was started on single anti-hyperglycemic agent to be taken twice daily. The name and dose she did not remember. She continued the same medication for approximately 15 years. Her blood sugars were controlled with occasional fluctuations during home monitoring, and there was no episode of hypoglycemia. No history of headache, blurring of vision, floaters, or any intraocular injections. No history of tingling, numbness, sweating, muscle weakness, altered bowel habits, or orthostatic symptoms. No history of swelling, shortness of breath, chest pain, and palpitations. Patient was on regular follow-up with her doctor. In 2014, she had a traumatic left ankle fracture, which was managed conservatively with painkillers, which patient approximately took for 2 weeks. In 2017, she was admitted in hospital in view of cough with expectoration, which was associated with fever but no hemopsis. Her creatinine at this time was found to be 3 mg per deciliter. She had adequate urine output. During hospital stay, her BP was found to be elevated, and she was started on 2 antihypertensive medications. She underwent urine examination and ultrasound whole abdomen, and her doctor told her that she is passing some amount of protein in her urine. In view of her poor glycemic control, injection glargine 10 units at night and injection human regular insulin 12 units was added. She was discharged after 5 days. In 2019, attendants informed that she's bedridden since 2019 for bilateral knee restriction of movement and pain, not associated with any small joint pain. Orthopedic opinion was taken and she was told that she probably requires bilateral knee replacement for bilateral osteoarthritis knee. She was managed conservatively with limb physiotherapy and occasional consumption of painkillers. She continued with her oral antihyperglycemic agent, antihypertensives. Attendant recalled that her creatinine was gradually rising and reached 5 mg per deciliter in July 2021. No history of nocturia, hematuria, proturia, decreased urine output, graveluria, urgency, incontinency, increased frequency or recurrent UTI. No history of loss of appetite, easy fatigability, altered sleep pattern, nausea, vomiting, altered taste, shortness of breath, swelling, backache, weight loss, bleeding from any side. No history of abdominal pain, jaundice, blood transfusion, hematemesis or loose motion. No history of cough, hemopsis, oral ulcers, hair loss, fever, skin rash or alternative medication. Patient lost to follow-up for approximately 1 year due to financial reasons. In first week of January 2023, patient had one episode of altered sensorium at home, which was not associated with any headache, vomiting, abnormal jerky movements or motor deficit. She was taken to hospital where her blood glucose level was found to be low. The attendant said it was less than 50 mg per deciliter. In investigation, the creatinine was 7 mg per deciliter and ABG had potassium of 8 mg per deciliter. She was admitted in ICU and 3 sessions of alternating hemodialysis were done through right IJ hemodialysis catheter. No blood transfusion was done during this time frame. Attendants informed that her urine output was around 2.5 liters during ICU stay. Attendants were given the option for renal replacement therapy. They chose peritoneal dialysis as modality for renal replacement therapy as the patient was bedridden. Peritoneal dialysis catheter insertion was done with no post-procedure complication. Her insulin and oral anti-hyperglycemic agents were stopped. Injection erythropoietin 4000 international unit was added, and her antihypertensive at discharge included tablet metoprolol 25 mg BD, tablet clonidine 0.1 milligram PD, tablet cilindripine 10 mg PD, and tablet prazosin 2.5 milligram PD. Attendants informed that her appetite had decreased from 2 chapati per meal to approximately half chapati per meal. CAPD's training was started after 2 weeks in end January 2023 with her son as caregiver, initially with 500 ml 1.5% dextrose hourly for 4 hours, which was further escalated to 500 ml 1.5 dextrose 2 hourly for 4 times a day. After 5 days, her prescription was stabilized to 1.5% dextrose 2 liter bags per day, 4 exchanges with ultrafiltrate volume of approximately 1000 ml per day and urine output of 1.5 liters per day. There was no inflow or outflow pain, any blood in effluent, shortness of breath, localized abdominal swelling or protuberant abdomen. She was continuing with the same prescription until 2nd April 2023 when patient developed pain abdomen, that is 10 days back, and which was sudden in onset, continuous in nature, dull aching, generalized with no radiation, associated with fever but no association with nausea, vomiting or meals. There was no jaundice, bleeding, PR. Patient took antacids for the same and was partially relieved. 6 days later, she developed change in color of the drain fluid bag and attendant could not read newspaper across the PD bag with UF maintained at around 1000 ml per day. Patient was out of station and could not report to hospital. There is no history of pet domestication, change in caregiver, hand hygiene, invasive procedure, change in bowel habits. Patient reported to hospital on 12th April 2023 and was admitted with us in view of above mentioned complaints. Initially, few rapid exchanges were done in view of pain. Later, her old prescription was continued, that is 1.5% dextrose, 2 liter, 4 exchanges per day. Her transfer set was changed and PD fluid was sent for analysis and culture. Her cell count was found to be 650 cells per microliter as told by the attendant. She was given loading dose of injection vancomycin, ceftazidime and heparin. Later antibiotic were given in each bag. In injection vancomycin was given after 5 days. Her culture report is awaited. Patient felt improvement in her symptoms over next 48 hours. Her PD fluid color also changed to straw color. On direct questioning, she told there was no pus discharge or redness at exit site or no soakage. Presently, she is on intraperitoneal antibiotics. Medical history, she received 2 doses of COVID vaccines in 2021. Past history, there is no history of CAD, CAB or tuberculosis. She is diagnosed case of osteoarthritis bilateral knees since 2019. Family history, her father died at the age of 62 and he was a case of type 2 diabetes and CKD. Menstrual history, she had a menarche at 13 and menopause at 55. She has 2 sons, 30 and 55 years old respectively. Both were normal vaginal delivery and there is no history of pregnancy loss, hypertension in pregnancy.
So there's a good history. Summarize. What do you think you are dealing with?
So summary, my patient Mrs. US, 65-year-old female, diabetic for 25 years, with history of left ankle traumatic fracture in 2014, admitted in 2017 for LRTI, diagnosed to have hypertension, proteinuria, and renal dysfunction with creatinine of 3 mg per deciliter.
Just summarize.
Okay. Very important. Two very important things. You have taken a very nice detailed history. How long did it take you to take this history?
45 minutes, excluding the exam.
I can assure you can't do it. I'll give you a patient right now. You cannot take up history for 45 minutes, write it, and present it.
Negative history.
I can guarantee that to you.
Yes.
This is the problem. All of you are final years. You have to give exams. You have to present 4 cases. You will get 20 minutes to examine the patient, 5 minutes to write it. Examiner will have 15 minutes. So if you don't practice your history taking that way now, you will falter in your presentation, in your exam, and this is where you falter. You will be given, and most of the time, either the center will give you 2 cases or all 4 cases. कि एक के बाद एक देख लो, खाली हो गया आप चलो उधर. That is the time, because now what you have got, you have taken 2 days to take the history. You know the patient is admitted with you, and you go through it. You know the documents. You go read about it. Then you come back and take your negative history. This is where you will falter in your exam. Finally, you have to pass the exam. Second part, in between taking this huge history, you have missed out something very significant in your history. What is the significant history is missed out?
Anybody?
This is again a problem.
See, the thing is, there is really no differential in diagnosis. What is the etiological diagnosis here? So we don't want to waste time. Kya hai? I don't want to run into say CGNA, amyloid, because nothing is going to judge. It is cut and dry: diabetic nephropathy, end-stage kidney disease, peritoneal dialysis, PD peritonitis. Right. So differential नहीं है यहाँ पे. यहाँ पे we have to go in a different way. So as my colleague says, what are two important things he missed?
History has to concentrate on what your presenting complaint is. Correct? If I were you, of course, every teacher of yours will have a different viewpoint, obviously. But I would say patient at the age of 45 developed hyperglycemia, whatever age, came to know that time creatinine was this much, in this much time it became this much, and by this time it went to end-stage renal disease, and patient needed to be started, also had hypertension. There were no symptoms of target organ damage, osteoarthritis. Right? Now you put your osteoarthritis in your present history as well as your past history. How can it be both? Now, what is the important part of CAPD history which you have missed? Which is glaring.
About what you should anybody. See, it's supposed to be interactive, right? We are not like schoolmaster, neither you are in grade 10. So it's supposed to be interactive. If you are not interacting, you are all wasting 30-40 hours of your life. Man hours.
Who does the CAPD for?
I told the son as a caregiver.
So, was there a change in the caregiver when the person? He did. Okay, then I missed it. What other history?
He said his son gave it.
Sir of CAPD.
Anything in this history. और क्या होना चाहिए था इसमें? See, we cannot pretend that patient को CAPD नहीं हो रहा. You know the whole CAPD prescription. So what else should have been involved in history peculiar to CAPD?
Dietary history.
You didn't say anything about how the prescription was made to the patient. CAPD prescriptions are not made empirically. Why was he given 1.5 into 4 bags to start with? What was the rationale for that? That is the question. That should have been answered in the history itself. Do you agree? आप लोग इधर आ जाओ. थोड़ा जितने लोग इधर आ सको. और इधर आ जाओ पास में इधर आ जाओ. क्योंकि see, you are not super specialist. अभी आप MBBS का या MD का एग्जाम नहीं दे रहे. So we all know that we are dealing with CAPD. We are dealing with a diabetic end-stage disease, CAPD.
Especially when a person can tell you what antibiotic, what dose, what creatinine, what strength. Then if you say कि किस basis पे
मतलब okay, let me rephrase this question for you. If you were to write a prescription for her, because after passing out, I am sure you are coming from a good institution, you will have your own good practice. How will you write the prescription now?
So first the strength of the.
No, write in the prescription. What are your parameters to describe? You are following what I am saying? You are on page with me?
CAPD में prescription. How will you initiate CAPD? That is the basic question.
Sir, initially we start with low.
नहीं
1 meter.
वो mechanism है, वो methodology है. That is method. वो क्यों करते हैं? कि leak वगैरह ना हो.
Cytokines and.
वो सब. I'm asking the prescription. How you make out the prescription? Empirically बनाते हैं क्या prescription CAPD का? That is why the problem in CAPD. India पे CAPD बिना चलता नहीं है. Anybody? CAPD prescription कैसे बनना चाहिए?
Take a guess. You are all seeing CAPD patients. I'm sure most of you are.
Sir, we do incremental.
Make your mistakes here. Don't make your mistakes in
नहीं,
there.
There is a way. क्या yardsticks होते हैं CAPD के decide करने के लिए?
If the patient is fluid overload.
Urine output.
Obviously, तो PET test करोगे 3 weeks after the CAPD is in place. Why do you do PET test? What is the advantage of doing PET test?
So we get to know about the peritoneal membrane functional characteristics.
उससे क्या होगा?
We know the type of transporter the patient's peritoneal membrane is. And
तो वो तो कहीं हिस्ट्री में आया नहीं. And what was the rationale of giving 4 bags 1.5? What was the dwell time of each bag?
sir, 5 hours and right night dwell was almost 10 hours.
So 5 hours for 1.5% bag. क्या होगा पेशेंट? तुम्हारे ख्याल से अब कैसे करना पड़ेगा? पेट तो किया नहीं तुमने. पेट किसने डिस्क्राइब किया था फर्स्ट टाइम? वो ये लोग अक्सर साइंटिस्ट के नाम पूछते हैं.
Trodowski.
वेरी गुड. Zublev Todorsky, a Polish US citizen, he was a genius. उसने पेट डिस्क्राइब किया था, राइट? सो पेट तो किया नहीं, अगर पेट करते हो तो क्या डिस्क्राइब, क्या एक्सपेक्ट करते हैं इसी पेशेंट में विद दिस अमाउंट ऑफ हिस्ट्री दैट वी नो? तो हमारे ख्याल से पेशेंट किस टाइप का आता है, पेट के तो सब पता ही होगा तुम्हें।
Yes, sir.
आई डोंट वांट टू गो इनटू दैट बिकॉज़ तुमने प्रिपेयर किया, आई एम श्योर यू मस्ट बी नोइंग अबाउट पेट। तुम क्या एक्सपेक्ट करो, कैसा इसमें पेट हुआ होगा पेशेंट का, कितने टाइम ये ठीक चले, कितने टाइम ठीक चले इसके एक्सचेंजेस?
Sir, almost January last में we started with the CPD.
ओके, और कब तक
And
ठीक
April-
चली बिफोर पी केम?
One month, one and a half months, sir, because
So after starting 1.5 months of CAPD, what was the patient like in terms and what yardsticks you would be looking at the patient? अगर OPD में आएगी तुम्हारे, क्या क्या देखोगे? You are the consultant now. Forget Ashwini and Anil Bhalla.
sir, the nutritional status, the quality of life the patient
क्या
has.
क्या देखा है इसमें? कुछ आया नहीं ना हिस्ट्री में? न्यूट्रिशन स्टेटस कैसे देखते हैं? कैसे देखोगे?
Sir, BMI.
BMI, चलो, क्या था BMI इसका?
Sir, BMI is 47.
तो क्या हुआ? खराब हुआ न्यूट्रिशन भी ठीक हुआ? और क्या देखोगे? जल्दी जल्दी बताओ यार, you are losing time.
Sir,
As Colonel Mukherjee has said, in DNB what normally happens is you are given 4 cases. और वो क्या करते हैं, एक स्पेस तुम्हें दे देंगे, तुम्हारे चारों केस वहाँ लिटा देंगे, एक स्पेस तुम्हें दे देंगे, you are with your patient. In a stipulated period of time, आप चाहे सारा टाइम एक पेशेंट पे लगा दो, which will be foolish, या आप उनको एलिक्वेट टाइम में देखो। कुछ जगह पे ऐसा करेंगे, आपको एक केस देंगे, फिर अच्छा खत्म हुआ तो उधर चले जाओ, खत्म हुआ तो इधर चले जाओ, टाइम जोन सबके लिए सेम रहेगा। और वो ये इसलिए करते हैं वो लोग, दे डू इट फॉर द रीजन कि सपोजिंग आप सबको एक एक केस मिला, अब हमने यहाँ से वाइवा स्टार्ट किया, तो जो पीछे बैठे उनको डिस्प्रोपोर्शनेट टाइम मिल गया ना लिखने के लिए और सोचने के लिए, तो उसको वो करने के लिए, इक्वलाइज करने के लिए, दे विल गिव यू ऑल द केसेस टुगेदर, और आपके दो तैयार हो, अच्छा आ जाओ, फिर आप इधर से आ जाओ इधर से, तो इक्वलाइज हो जाता है। चलो बताओ क्या एक्सपेक्ट करते हो इसमें पेट में?
sir,
क्या इसका कैसी रही होगी मेमोरी इसकी?
was a high transport time.
हाई, और 6 घंटे का 1.5% पे, यू एग्री विद दैट? नॉट अ गुड आंसर। और अब कैसी हो गई होगी पेरिटोनाइटिस के बाद?
She is
पेट हुआ है इसका?
petty was.
In CAPD, it's normally PET should be done. Who besides him, who can describe PET to me? Anybody? सबको पता है ना P पे क्लास की कौन की? PET तो बहुत इम्पोर्टेंट है, प्रैक्टिस के लिए भी इम्पोर्टेंट है, हम लोग करते नहीं है इंडिया में, ये अलग बात है, ह्यूज रैमिफिकेशंस। कौन डिस्क्राइब कर सकता है PET?
What are the types of PET? PET, etc.
बैठ के बताओ यार, we are into a discussion mode. I just want to
ये तो
stimulate
एक
your
हफ्ते से
thought.
पढ़ रहा है तो इसको नहीं पूछेंगे।
So modified pet test, then a modified pet test, mini pet.
और can you add more?
Double meaning and standardized pet test.
And what is the difference between a standard PET and a rapid test or ultra?
Rapid test and standard test, which Todosky described.
Difference?
Sir, in standardized PET we use 2.25 strength of dextrose, which tells about the
2.5. 2.5
2.5% of
या
dextrose,
2.37 कहो, 2.25 कुछ नहीं है ना?
which tells about the transport status of the membrane, and in modified PET test we use 4.5%, which tells about the ultrafiltration failure.
कैसे करते हैं इसको?
Sir, we keep the patient for overnight dwell for 8 to 12 hours. We make the patient sitting position. We drain the volume, and then we again instill 2 liters of water and ask the patient to roll.
Water?
Sorry, dialysate fluid.
ऐसे मत कहो।
Peritoneal
Acid
dialysis
fluid is
fluid.
not water. What is the composition of dialysate fluid? एग्जामिनर ऐसे करेगा, वो एग्जामिनर को तुम्हारे वाटर से इरिटेशन हो गया, वाटर तो नहीं कह सकते ना CAPD बैग को. What is the composition of dialysate fluid?
Sir, sodium of 132 or 134 millimoles.
कभी ये सोचा है कि 136 क्यों नहीं है बैग में? ब्लड में क्या सोडियम है?
135 to 145.
क्यों नहीं किया बैग में 132?
Sir, वो it can cause translocational hyponatremia.
ट्रांसलोकेशन
Hyponatremia.
अगर 136 कर दोगे CAPD बैग को तो ट्रांसलोकेशन हाइपरनेट्रीमिया करेगा.
मतलब yes sir, it will drop to it.
ये थोड़ा हाई फाई सवाल है. I will leave it at that. I will not take it against anybody. ये थोड़ी फिजियोलॉजी का सवाल है. चलो आगे बढ़ो. और क्या
Sir,
होगा?
lactate 35 or 40.
एक वैल्यू बताओ.
35.
और 40 होती
sir,
है क्या?
Calcium of 1.25 millimoles or 2.5 milliequivalent per liter.
लो कैल्शियम बैग और नॉर्मल कैल्शियम
And sir, magnesium of 0.25 millimoles.
और 0.5
And
और पोटेशियम.
potassium no sir. Potassium no.
So CAPD बैग आपने. Then
Sir, we ask the patient to roll over the bed after every 400 ml, and and then we take the samples at 2 hours.
how
Serum
much
samples.
fluid you will take out?
Sir, we take 200 ml out and we take 10 ml out.
ये सब
of it.
चीजें आपको आनी चाहिए. CAPD में अनलाइक जनरल नेफ्रोलॉजी लिमिटेड चीजें हैं. CAPD में अच्छी बात ये लिमिटेड क्वेश्चन है, लिमिटेड चीजें आपको आनी चाहिए. कनेक्टोलॉजी पता होना चाहिए आपको, थोड़ी हिस्ट्री प्रोडोस्की आपको पता है. वेरी हैप्पी टू हियर दैट. एंड चलो 200 इज द राइट आंसर. फिर क्या
And then
करते
we
हैं?
instill the 190 ml back to the drain bag.
10 ml का क्या करेंगे?
We send it for the samples.
कैसे करते हैं उसको?
Sir, we send it to the lab. The serum sample at 2 hours and the peritoneal fluid samples. And we
And what do you
calculate
see?
Sir, we calculate the D by P ratio, dialysis divided by the plasma concentration of glucose, sodium, and creatinine. And that's how we calculate the D by P ratio.
DYP आपका अलग अलग होगा ना?
हाँ sir.
DYP ग्लूकोज होगा.
Yes, sir.
DYP सबका इकट्ठे थोड़ी
No,
करोगे.
sir. Yes, sir.
राइट. तो DYP ग्लूकोज क्या बताता है? व्हाट डज इट टेल अस?
Sir, equilibrization between the dt by d0, like how fast the glucose is being equilibrized between the serum and the PD fluid.
Yes, you are partly correct. Basically, okay. Let me ask you this way: how will you define the dose of dialysis? Basically, how will you define the dose of dialysis? क्या क्या yardsticks है उसके? मैं pertinacity से तुमसे end में बात करूँगा.
Sir, we calculate the D by P ratio and then we multiply it by the drain volume, which gives us the creatinine clearance.
नहीं एक D/P रेशो किसका क्या है?
Sir, urea का.
यूरिया और क्रेटिनिन क्लियरेंस बता रहे हो?
Sorry sir, urea के
See,
लिए.
ये तो बहुत एम्बैरेसिंग बात हो गई ना. देखो पहले बताओ क्या क्या चीजें हैं देखने के लिए डायलिसिस डोज, और क्या क्या चीजें डायलिसिस डोज में देखते हैं. ये रख दो यार. आई डोंट थिंक यू नीड अ मास्क.
Sir, we
Sorry, you don't need a mic. Let me tell you, they gave a good account of your history, but he has a point. Don't take it other way. Your history was very good. उसमें कोई कमी नहीं थी. But then you have to go forward.
So sir, we target the KT by V value of 1.7 and
So what is KT by V, my dear friend?
sir, it tells about the adequacy of peritoneal
Do
dialysis.
you think KT by V is synonymous with adequacy?
No sir.
बहुत अलग अलग वर्ड बोल रहे हो. मैंने पूछा था मार्कर्स ऑफ डोज ऑफ डायलिसिस. व्हाट आर द मार्कर्स ऑफ डोज ऑफ डायलिसिस? एक तो KT by V है, KT by V यूरिया.
हाँ sir. और एक creatinine clearance.
Right. So एक आपने यूरिया का डोज देख लिया, एक आपने क्रेटिनिन क्लियरेंस देख लिया. कैसे देखते हैं?
Sir, creatinine clearance का
आता है यार. कॉन्फिडेंस हो तो
45
एग्जामिनर आके तो
liters.
नहीं दे देगा ना. लो बेटा DNB ले जाओ, आए इतनी दूर से. एग्जामिनर कुछ तो पूछेगा ना. उसको TAD मिलता है सवाल पूछने का. कुछ तो सवाल पूछेगा ना एग्जामिनर. ये तो चेक करेगा ना कितने पानी में हो.
Sir, creatinine clearance is calculated by D by P of creatinine into drain volume, and we calculate it for a week. And sir, it is divided by the volume of distribution, which is weight multiplied by 0.6. And sir, if we want the weekly, we have to multiply it by 7. So that gives us the weekly creatinine clearance, which is the target says it should be around 45 liters per 1.73 meters square.
45 liters कहीं नहीं लिखा।
Keto.
45 liters लिखा है। creatinine clearance कम बता रहे हो।
Generally,
KT by
we
V
70
है।
we keep it, but 45 I read
मेरे को कब लगा 45? KT by V कितना होता है?
1.7.
1.7 as minimum.
Yes.
So if you want to give 1/7, थोड़ा और ज़्यादा देना पड़ता है because lot of time is lost in changing fluid and all those things, right? Okay. तो adequacy में क्या होता है? ये तो dialysis dose हो गई. Dose, what things you want to see in dialysis dose? क्या-क्या parameters देखना चाहते हो? Basically, what I am asking, let us be on the same page. What do we want to see in a PD patient? क्या-क्या दो चीजें mainly देखना चाहते हो? जिसके लिए डायलिसिस डोज बनी है।
Sir, urine output.
नहीं, वो तो रेसिडुअल है, उधर मत जाओ। वही तो रेसिडुअल यूरिन से चलता है, पीडी से नहीं चलता है। फर्स्ट यू वांट टू सी सोल्यूट क्लियरेंस, भाई कितना यूरिया निकला, कितना क्रिएटिनिन निकला, राइट? डोंट राइट इट, एवरीथिंग इज देयर इन द, जस्ट ट्राई टू रिमेंबर व्हाट इट इज। एंड सेकंड थिंग यू वांट टू सी इज द फिल्ट्रेशन, फ्लूइड। वही चीज तो देखनी है ना। सोल्यूट का सरोगेट स्मॉल मॉलिक्यूल का यूरिया है। यूरिया का केमिकल स्ट्रक्चर क्या है?
60 डाटा.
केमिकल स्ट्रक्चर पूछा मैंने, सवाल सुनो,
Sir, CO
मॉलिक्यूलर वेट नहीं पूछा।
CO N2 and
ये बहुत नेगेटिव होता है। अब वो कैसे एग्जामिनर ने एकदम से पूछ लिया? एग्जामिनर को तो कोई बाइंडिंग नहीं है ना दादा। CO N2 कहोगे तो आई बी वेरी अपसेट, क्योंकि फिर तो मैं तुमसे अभी उसकी बहुत सारी बातें करनी, न्यूट्रिशन की सब कुछ हो ही नहीं पाएंगे। He is a good boy, he is coming from one of the top centers, but अगर यूरिया का केमिकल स्ट्रक्चर नहीं बताओगे दिक्कत हो जाएगी, right? So all of this is written in stone. CONH2 से NH2। क्यों पूछ रहा हूँ यूरिया का?
Sir, nitrogen balance.
नाइट्रोजन का एटॉमिक वेट
28, 48, sir.
40, quite right। तो यूरिया में कितना नाइट्रोजन हुआ?
And
28। ये आगे काम आएगा, इतना ध्यान रखना है, इतना ध्यान रखना है, बहुत काम की चीज है। चलो और बताओ। तो सोल्यूट क्लियरेंस आप देखो KT/V से और क्रिएटिनिन क्लियरेंस से, और वॉल्यूम कैसे देखो?
sir, drain volume से और PET test करके.
कैसे? पेट टेस्ट से वॉल्यूम का क्या पता लगेगा? वॉल्यूम स्टेटस की बात करो। ड्रेन वॉल्यूम से देखोगे,
Drain volume से.
और रेसिडुअल यूरिन देख लोगे, दोनों को ऐड कर लोगे, यू विल गेट द टोटल डायलिसिस डोज। यही है ना?
So to complete your this thing, just tell your diagnosis and any positive and relevant negative findings.
Sir, final diagnosis. CKD5 on peritoneal dialysis, basic disease, diabetic kidney disease. On 4 exchanges per day, 1.5% dextrose, 2 liter bags. Urine output 1.5 liters per day. Type 2 diabetes with triopathy, hypertension, osteoarthritis, bilateral knee. Now presented with CAPD peritonitis.
Positive and negative findings. Clinical.
Findings, examination।
Sir, she had her fundus was suggestive of moderate non-proliferative.
It's a bad way to start examination।
Oh, I'm so sorry.
If you start with fundus, so I'm sure you have not seen the fundus।
Sir, her BMI was 47.11. BP was comparable in bilateral upper limbs, and pulse dorsalis
तो
pedis
बता
was
दे
not.
मेरे भाई।
Sir, BP was 132/86 in right arm, left arm 130/84.
वो ठीक है, 130/86 है, नॉर्मल पल्स बोलिए।
Dorsalis pedis was not palpable, sir. In per abdomen examination,
पल्स कितनी थी भाई?
pulse rate 92 per minute. Sir.
These things you have to tell। पल्स बीपी तो बताओगे ना, रेस्पिरेटेड पर मरीज जिंदा ही नहीं है, आप लगे होगे। चलो।
Sir, in per abdomen examination, she had infant like a PD catheter in situ with no redness or fluid leakage at the exit site, no edema, and
Did you see the exit side?
yes, sir.
तो चलो आप बस
And sir, in CBS,
In
her
CAPD
FX
you are expected to see the exit side in the examination, but जो वहाँ पे होते हैं they may tell you आप मत देखिए because then you have to dress it also. You can't just rip off the bandage and see, है ना? But you have to say I have seen it, I have not seen it. Exit side is extremely important for CAPD examination.
Sir, in CBS, her apex beat was in 6 intercostal space, lateral to mid clavicular line, and fundus was resting of bilateral moderate non-proliferative diabetic retinopathy.
So apex beat 6 intercostal space, character of apex beat. 6 intercostal space में क्या रहे हो यार? क्या मतलब हुआ?
Outward.
मतलब क्या हुआ?
Sir, left ventricular hypertrophy.
हाइपरट्रॉफी तो कैरेक्टर अब इम्पोर्टेंट हो गया ना. अगर अंदर एपेक्स बीट होती तो कोई बात नहीं थी. Then you have to say हाइपरडायनामिक एपेक्स बीट है या एएस वाली है, सस्टेन्ड या इल सस्टेन्ड है, चल कोई. और न्यूरोलॉजिकल एग्जामिनेशन में फंडस के अलावा कुछ देखा?
Sir, she is bedridden, so I could examine her tone and power in upper limbs only. And higher mental functions were.
लोअर लिम्ब में क्या प्रॉब्लम थी? पैरालाइज थी?
Sorry, sir, she had bilateral osteoarthritis and she is bedridden since 2019.
नहीं तो लोअर लिम्ब के एग्जामिनेशन में क्या प्रॉब्लम?
She was not very cooperative and she was in pain.
Normally, I would really appreciate if you could say something about ankle jerks, for the very simple reason कि अगर डायबिटिक न्यूरोपैथी होगी या यूरिनरी न्यूरोपैथी होगी 30-35% में एंकल जर्क हो जाएगा, है ना? So we would really appreciate कि क्या दो ankle jerk. At least I have that idiosyncrasy. Call it an. I'll be very happy if you tell me about ankle
You
jerk.
know that he has mentioned here as diagnosis triopathy. Where is the triopathy?
Sir, yes, sir. So in sensory examination, she had diminished sensation for vibration and touch.
So तो ankle jerk तो बता नहीं रहा, वो तो उसने देखने दिया तेरे को vibration और ankle jerk देखने नहीं दिया.
Sir, I distally examined her feet for
अरे यार vibration से देखा. Tuning fork कितने उसका था तेरे?
128.
128 का था. Is that the right frequency? ऐसे फंसता है. Actually मुझे थोड़ी न्यूरोलॉजी अभी भी unfortunately याद रह गई है. तो अगर ankle jerk नहीं देखा और vibration देख लिया, do you think it gels with you? Then let us be honest. Does it make sense? चलो आगे बताओ.
Sir, she had diminished sensation for pain and vibration in bilateral lower limbs.
कहाँ तक?
Distally. Toe, great toe and finger.
नहीं मतलब nerve pattern में था, glove stopping pattern में था.
नहीं sir, distally only.
Distally कहाँ तक? कितने dermatome तक?
Sir, sole पे and on the fingertips.
Neuropathic probably class है. चलो.
And sir, fundus.
Fundus में क्या बताया?
Bilateral moderate non-proliferative diabetic retinopathy.
Can you classify diabetic retinopathy? बता सकते हो?
Sir, we have non-proliferative and proliferative diabetic retinopathy, and in mild, moderate, and severe. Mild means that there are only microaneurysms. Moderate, we see cotton or soft exudates, and in severe, we see hemorrhages in all four quadrants in bilateral lines.
What is the hallmark of diabetic retinopathy? Hallmark क्या है? If you have a microaneurysm, the music has started. ठीक है? चलो.
And sir, proliferative में we see neovascularization or vitreous hemorrhage.
Okay. CAPD का था.
Ajay, tell us, what do you think was the cause for the peritonitis?
So probably the change in the technique, because the son was a caregiver and we tried to rule out all the risk factors like any pet at home or any invasive procedure.
तो हुआ नहीं.
हाँ sir, ऐसा. So probably the technique, faulty technique could be the reason.
So the it is the sterile process.
Yes.
Which is the single most important modification in CAPD since it started, which has reduced the incidence of infection
Flush before fill. Flush before fill.
before that?
Bisect by.
Correct. The preventing of spiking of the banks and then the flush before fill. These are the two most important things which has reduced the incidence of infection, which is paramount in success of CAPD. what should be the acceptable infection rate in a good center? Anybody?
Less than 50.
How much is it?
0.4 episodes per year.
0.4 what?
Episodes per year.
Episodes per year.
कैसे
0.4
डिस्क्राइब करते हैं इसको इन्फेक्शन को?
Says
इसका मेथड है
हाँ
डिस्क्राइब
sir. Sir, in numerator we take the episodes, and in denominator we multiply the number of patients into with months or either the years, and that's how we
What's it called?
episode per month or episode per patient month,
Patient years.
episode per patient year.
Patient, mostly patient.
What would be the average in a good center? What you have read in your articles?
0.6.
0.6 or so. Which country has the best record of CPD, lowest incidence of peritonitis?
Sir, I'm not sure.
Look it up if I remember.
What is CAPD first? ये तो जानते हो.
CAPD first policy, sir. We tend to prefer the PD as the first modality for renal replacement therapy because of certain benefits. It is more physiological and easy, cost-wise, and
Why do you
incremental.
call it more physiological? CAPD first is a term used in countries like Canada, Hong Kong, which very nearly always start end stage program with CAPD. They have some other reasons also, so they label it CAPD first.
It is a continuous process.
और फिजियोलॉजिकल हो गया. किसी के स्टेराइल मेम्ब्रेन में घुस के 4 दफे पानी डालो एज इफ दैट पानी. फिजियोलॉजी.
As compared to kidney, the peritoneal membrane is at function 24 hours.
ठीक बोल रहे हो, बताओ ना.
And so there is
Complete your answer. It's a continuous form of clearance. If you start early, you have better
residual renal function.
anemia control, better renal function preservation. So that's why we prefer it.
Yes, sir.
Now, in a patient, which is the patient you would prefer to start CAPD rather than HD? All things else being equal, not talk about finances or anything. Patients where CAPD would be preferred modality of treatment.
Residual renal function patients. Patients with residual renal functions are preferred for PD.
Plus, that is one.
In children,
Pediatric patients. Patients with cardiac disease. Patients with liver disease. Patients with access, lack of adequate access. These are the people where you would prefer to start CAPD, of course not hard and fast. Which are the patients where you would not like to start CAPD?
obese patient,
Hernia,
Not really so much.
multiple previous surgeries,
Yeah, additions,
additions.
repeated episodes of peritonitis for some other reason earlier, where people have undergone bowel surgery, gastrojejunostomy, Whipples.
इस पे याद आया कि पेशेंट के एक यहाँ पे वो है ऑस्टमी है, लेकिन वो कहता मेरे को CAPD करनी है. कर सकते हैं?
Sir, we have to surgically correct it for it.
नहीं हो सही.
अच्छा, hernia, sir.
कर सकते हैं. वेरी गुड. क्या हो? जोर से बोले.
We use an extended catheter, sir. The catheter, the outlet is in the sternum.
स्टर्नम यहाँ निकाल देते हैं, एक्सिट साइड यहाँ बना देते हैं. So you are not touching the abdomen. Very good. So you do a cannulation here, and then you have a continuous long connector, कह लो, intermediary कह लो, कुछ भी कह लो, उसको embedded रहेगा वो subcut में. वहाँ से आपने उसको जोड़ा अंदर और यहाँ से निकाल दिया. इस पेशेंट का exit side ये हो गया. Quite right. You can.
What are the types of CAPD catheter you know? Okay. You and you.
Type of CAPD catheter तो
Catheter का नाम बता दो. दो तीन तो
इतना नर्वस क्यों हो जाते हो? दो तीन तो बता दो, मुझे कौन से 12 याद रहेंगे?
Standard catheter.
What are the types
Sir,
of
acute
catheter?
rigid catheters. Acute rigid catheters. Acute rigid catheter. Cuff, non-cuff. Single cuff, double cuff.
So,
Swan neck.
CAPD catheter may be single cuff or double cuff. They may be straight catheter, they may be curl catch, they may be swan neck, and What are
जलेबी मिजूरी पूरा वो
Sorry,
जलेबी
please look it up. Please read this thing.
जलेबी पूरी देखा है
Most
उसका
of your
diagram में
third
देखा
years,
होगा
you'll be going and you'll get a CBD case.
स्पॉट में भी रख देते हैं कभी कभी they keep a spot
So if you don't know what are the types of CAPT catheters, it's going to be very difficult. What are the commonest organisms causing CAPT peritonitis? The girl behind you.
Staph aureus,
That
जोर से बोलो बेटा
Enterococcus,
और
Staph aureus, then
The complex negative staph epidermalitis when it is associated with such the site,
touch
exit site, and E. coli.
gram-negative organisms, if they are translocating from the intestinal tract, if it is due to an exit site or a tunnel infection, they will be usually gram-positive. That is why when you cover peritonitis, you generally cover with a gram-positive cover and a gram-negative cover. Am I right? Okay.
okay so besides CAPT peritonitis what other problems you envisage with CAPT
Complications.
problems that you can face with CAPT ये तुमने देखी होगी
Complications with it. Sir, patient can have metabolic complications in form of hyperlipidemia, hyperglycemia, metabolic acidosis.
why should you have metabolic acidosis
That's a very wrong way of answering questions. Now you have to answer questions to the examiner. Examiner आपके DNB में won't have 1.5 hours to ask you questions. You'll have 15 minutes. In 15 minutes, either he has to keep saying what else, what else, what else. Even if you don't, you don't. When you answer a question, you have to talk about complications. You have to be very clear. You have to classify your answer. Either they can be early complications or late complications. There may be surgical complications or medical complications. Then only you can go ahead. If you just say metabolic complication, that doesn't mean anything.
वैसे भी exciting नहीं लगता ना metabolic सबको पता है hypertriglyceridemia hyperglycemia और बताओ चलो और important mechanical complications
Sir, there could be catheter malfunction or
क्यों
obstruction.
होता है catheter malfunction
Sir, initially it is early malfunction can be because of constipation, fibrin flux. Later it could be because of the omental wrapping.
momentum initially भी एकदम हो सकता है next day only your catheter will migrate कर जाता है ऊपर okay what else और क्या complications देखे तुमने anybody
Catheter
Hydrothorax.
migration,
very
bowel perforations, catheter migration. These are all known complications. Catheter
case
breakage,
reports of bowel perforation by CAPT by
and not just during insertion, it may happen later also.
long later
So these answers have to be given. What are the methods by which a CAPT catheter can be inserted?
Sir, laparoscopy, percutaneous, or surgical.
Surgical, laparoscopic, and percutaneous. Anything you have missed? Peritonioscopy, which is used, which is not laparoscopy. SGPGI is very fond of doing it. I don't know whether Gangaram does it. But peritonioscope, which Dr. S.K. Sharma and his team, they use it a lot to do insertions. Okay. What is the advantage and which are the patients where you would like to do a surgical insertion?
So patient who have had some surgeries, history of surgery, where they're likely to have some sort of addition,
Okay.
and very obese patient.
What others? Children, because they have large omentums. Placement of catheters is more difficult. So you would like to do quite often surgical implantation because you can do an omentectomy at the same setting. Or else you go for a laparoscopy along with a omentectomy. Okay. How soon after removal of a catheter due to peritonitis can you reinsert a catheter?
Sir, after the culture is negative or neutrophils is less than 100 or
How soon?
Culture negative.
1 month, 2 months, 3 months. आपने तो कैथेटर निकाल दिया, कल्चर नेगेटिव कैसे देखोगे? So go back and read on that. How soon? The patient will ask you, when can I go back on CAPD? Okay? They will know. Okay. What is the status, volume of a normal CAPD bag? एक बैग होता है ना, उसका वॉल्यूम कितना होता है?
2 liters.
2 लीटर. What are the other volumes?
2.5 to 3 liters.
And
APD में we use 5 liters.
1 liter bag also.
1 liter bag.
For specifically for children. Okay. What are the different kinds of constituents of CAPD fluid?
APD fluid.
एक तो आपने बोला glucose based. What else?
Icodextrin based, amino acid based.
Right. Okay.
Amino
Amino acid based. What is the advantage of amino acid based solution?
So these are basically glucose sparing agents we can use for patients having uncontrolled hyperglycemia.
Anything else?
For the last year, I am patient with nutritional not maintaining their daily protein intake.
Okay. What is the problem with glucose based solutions?
Sir, they can damage the peritoneal membrane function in long term because of the generation of glucose degradation products.
So what are the ways of preventing this?
Sir, we can use the least concentrated solution.
One, yes, very good. What else?
Icodextrin, amino acids.
2, 3,
And we need to preserve the urine output. Sir, that is general.
how do you prevent glucose based issues?
Sir, the pH we can use 2 bag system because
Correct. You have to answer that.
वही सुनना चाहिए.
वही तो सुनना चाहते हो. So either you reconstitute and make the fresh, because GDP also takes time to generate. So if you use that, what is tri-choice or 12 bag, or you use icodextrin. What is icodextrin?
it's a polyglucose.
What is the advantage of icodextrin?
Sir, the reflection coefficient of icodextrin is 1, so it just leads to the ultrafiltration.
What is the reflection coefficient? Check, sure. Behind you. Behind you.
Reflection coefficient, it is depend on the sleeve. So reflection coefficient is basically depend on the sleeve for how much longer.
What is a reflection coefficient? What is the reflection coefficient? You said it's 1. So what does it mean?
Sir, when the substance hits the pores, small pores and ultra pores, it reflects back, and it is not basically the diffusion into the capillaries. Diffusion
Okay.
back.
When you use a term, you must understand.
You must
that term.
understand.
Diffusion.
What does it mean? Suppose it's 0.5. What does it mean?
50% of it crosses out and goes into the
Sure.
circulation.
And 2?
Sir, it's
Bounces
between,
back faster.
it's between 0 and 1 actually.
Yeah,
Between zero.
absolutely.
Quite.
Absolutely. Glucose has a low reflection coefficient because it gets absorbed.
Yes, sir.
Icodextrin doesn't. But to some extent, icodextrin does get absorbed and it accumulates.
Yes, sir.
What are the problems with accumulation of icodextrin?
Sir, maltose generation and then patient can have rash.
So maltose में problem क्या है? So what? Glucose का है maltose होगा तो क्या होगा?
Sir, it hinders the estimation of glucose estimation methods.
What is it?
Maltose.
Human body can't metabolize maltose. That's
Just
what
like
we don't have the enzymes. So we cannot metabolize maltose. Correct?
Yes.
Am I right or wrong? What is the other shortcoming of icodextrin?
Shortcoming.
What are the problems with icodextrin? So you said it's better than glucose. So why don't I do all that well with icodextrin? Why use glucose at all?
Sir, it requires a longer period, approximately.
So you can't do
10 to
short
12 hours.
exchanges with icodextrin. As simple as that.
Yes, sir.
Correct? You cannot do short dwell times with icodextrin.
And why can't you do short dwell time with icodextrin? कर लो.
निकालना ही पड़ेगा, निकाल लो।
हाथ में तो मेटाबोलाइज थोड़ी होता है। That is where you will have to understand the peritoneal physiology. Okay. Type of pores.
So 3 types of pores: large, small, and ultra small pores.
क्या
20 to
size
40
है?
nanometers for small. Large pores 4 to 6 nanometers for small, and less than 0.6 for ultra pores. That is aquapores.
फिर से बोलो सर।
So 20 to 40, 4 to 6 nanometers, and less than 0.6.
Confusion हो रहा है। How will you see the efficacy of ultra pores?
Sir,
Size में मेरे को थोड़ा confusion
Yeah.
check कर लेना।
Sir,
4
when
to
we do
6
the
याद है,
modified,
10 to 20 याद है, more than 50 याद है।
sir, when we do the PET test with 4.5% and 2.5% dextrose, the difference between the initial 30 minutes or 1 hour, the drop in sodium should be less than 5 in less concentration and more with 4.5. When it is less than 5
क्यों
milliequivalents,
drop होगा sodium?
sir,
Why will sodium drop?
sir, actually the initial 30 minutes to 1 hour function is taken by the aquaporins, and that only seals and takes out the water.
Let us
Ultrafiltration.
say 1 liter fluid is ultrafiltrate in a patient. Okay. How much will go through aquaporins?
45%.
Quite. अब वो सोडियम का क्या पता है?
Sir, initially 30 minutes to 1 hour only ultrafiltration takes place, and that is to the ultrapores, aquaporins. Later on,
तो
small
इससे क्या
pores.
होगा? सोडियम को क्या होगा?
Sir, it will dilute the sodium. It will
In blood patient कहाँ पे?
patient.
Patient में dilute करेगा.
Sir, PD fluid because it is destroying water.
पीडीएम बाहर आ रहा है
132 से sir it goes back low to 128.
What is that called? Sodium sieving. So sodium sieving से you will have a fair idea कि aquaporins आपके ठीक हैं. That is one thing. Otherwise जो तुम बता रहे हो कि ultrafiltrate कितना है 2.55. Okay. What will happen to this patient now after peritonitis?
Her transport status may change.
Like
If she's high, then she might go into average. Like
Really?
during peritonitis, sir, peritonitis converts the membrane characteristics to high
high से
transporter.
low average कर देगा.
During peritonitis, it will go to high transporter.
During peritonitis nobody does the PET test. Nobody, as far as I know, does the PET test. I trained in the Mecca of CAPD with Dr. Oriapoulos. Nobody does PET test in peritonitis. Okay. Once the peritonitis is extinguished, then you will repeat the PET and you expect high to become low. After peritonitis, you agree?
Sir, there is sclerosis and adhesion
तो low
In long
transport
term,
हो
sir.
जाएगा.
in long term.
हाई से लो तो बेटर हो गया ना. आउटकम्स किसमें बेटर है सीएपीडी में? हाई ट्रांसपोर्टर्स में, लो ट्रांसपोर्टर्स में? हु हैज बेटर आउटकम्स?
You have two patients here, high transporter, low transporter.
Sir, low transporters are ultimately transition to HD. So if we want to continue
ये
peritonitis,
कहाँ किसने कहा लो ट्रांसपोर्टर विल अल्टीमेटली ट्रांजिशन टू एच? हु सेड दैट? क्या बोल?
low average.
पेट का आईडिया नहीं तुम्हें? एनीबॉडी? आई एम सॉरी, पेट का आईडिया नहीं तुम्हें? अनिल बल्ला तो काफी एग्रेसिवली करता है.
In many
Anybody?
of the centers, if CAPD is not being done, please go on a observership to a center of CAPD. CAPD is a major part of your therapy and major part of your exam. If the center where you get an exam is a CAPD center, then you will 100% get a case. If not, it will be there in your table viva or in your water course.
थ्योरी में भी एक आध क्वेश्चन जरूर है.
100%, 1/4 of your theory paper will
It's
be
not a
there.
good answer. Believe me, it's not a good answer. तुम अच्छा बता रहे थे. I did not find an answer. Normally, low transporters do better than high transporters. Why?
The answer is technique survival, patient survival. Which one is better? That is the answer you have to give.
समझ रहे हो बेटे बात?
Patients are
Technique survival is higher with low transporters. Always. High transporters have poor survivability of CABD technique. They are the ones where after some time you have to shift to HD.
To HD. High transporters will more often go to HD than low transporters. And when you do a PET test, this is the information you get from PET test. When you do PET test, you calculate D by P creatinine or you do D by D0 glucose. It tells you the transport characteristics of the solute, right? These are the two. And that will decide. Supposing phone आ गया. Hello.
Achha.
Hello.
Can you tell types of ultrafiltration failure?
Sir, there are 4 types of ultrafiltration failure. One is because of the increased transport. Seen in high transporter, it can be in the phase of peritonitis.
When you say you can say type 1 is this, type 2
High
is this,
transporter.
type 3 is this, type 4 is this.
So high transporter, type 2 is low transporter, type 3 is type 4
ऐसे
is
याद करने से बेटा फायदा नहीं. It's not important. What do you understand by type 1 ultrafiltration failure, which is most
high transporter.
मतलब
During peritonitis there is increased
इसलिए निकटमैटिस नहीं है. अब ठीक है. टाइप 1 अल्ट्राफिल्ट्रेशन फेलियर से आप समझते क्यों? What do you understand by it?
Sir, there is the effective peritoneal surface area on the capillaries increase.
तो
And
क्या होगा इससे?
There is increased transportation of
देखो
glucose
मैंने शुरू में
across.
कहा था हमेशा 2 चीजें देखी जाती है. सोल्यूट क्लियरेंस एंड वाटर क्लियरेंस. सीएपीडी में दोनों चीजें देखी जाती हैं. तो टाइप 1 में क्या है, टाइप 2 में क्या है?
So type 1 में solute clearance will be good.
और वाटर
Water will be poor. Like ultrafiltration will not be careful.
और टाइप 2 में
Sir, it is opposite.
दोनों में. दोनों में. और अदर अल्ट्राफिल्ट्रेशन फेलियर्स में क्या होता है?
Sir, type 4 is echoporin deficiency and type 3 is catheter malformation.
Lymphatics.
Lymphatics, sir.
ये काफी once you are exposing the membrane to lot of glucose load and all, the membrane surface increases and the lymphatics से क्या problem होगी? What problem lymphatics will create?
Increased absorption, sir.
सीधा सा सवाल है. ग्लूकोज सब वहाँ चला गया, तो ब्लड को ग्लूकोटॉक्सिटी हो रही है, शुगर्स बढ़ रही हैं और अल्ट्राफिल्ट्रेशन हो नहीं रहा. बाहर बैग में आपका अल्ट्राफिल्ट्रेशन हो नहीं रहा.
If you have peritonitis, should you add antibiotics to the peritoneal fluid or IV?
So the guideline latest ISPD peritonitis guidelines say if the patient is in sepsis or shock, then we do give intravenous antibiotic. Otherwise, we do prefer intraperitoneal antibiotic.
Why?
1.5-2 घंटे बाद.
Because the antibiotic has cephalosporins have time dependent effect, so they have better absorption, sir. And better absorption, sir.
क्या सवाल है?
मैंने पूछा एंटीबायोटिक्स इंट्रापेरिटोनियल बैग में देना चाहिए या आईवी देना चाहिए
क्या
पेरिटोनियल
बताया क्या सीखा?
बताया नहीं बता.
Sir, intraperitoneally, if not in sepsis.
Why?
Sir, contact time. Maybe the
कॉन्टैक्ट टाइप का आईवी में सबसे ज्यादा होगा. इसमें तो आप फ्लूइड निकाल दो फिर कॉन्टैक्ट कर.
sir, in this patient, if we talk, sir, patient has renal urine output reserve, so it will probably wash out in urine.
इसका
मतलब
तो क्या?
antibiotics to clear out in urine.
कितना रेसिडुअल रीनल वॉल्यूम होगा इसका? तुम सवाल का ठीक से बेटा जवाब नहीं दे रहे. व्हाट इज वांटिंग? बायोफिल्म का नाम सुना?
Biofilm.
फिर क्या बायोफिल्म क्या बोला?
Sir, bacteria do form a layer over the catheter, which is
वहाँ उसके
resistant to
पीछे
it.
उसके पीछे छिपे बैठे रहते हैं.
Yes, sir.
तो when you are giving intraperitoneal, you have more chances of touching those bugs at least who are sitting in the biofilm. Blood से biofilm में नहीं आएगा. Otherwise blood तो हर जगह एंटीबायोटिक को पहुंचा देगा.
Second is maintaining an IV access and giving IV antibiotic at home is usually more difficult. You need trained personnel. Introducing it into the bag where people are already used to putting insulin is better, but it has its own problems because you may again break the sepsis barrier in the bag. Correct. After peritonitis किसी तरह तो हुआ है, so if you are not introducing the antibiotic properly, you may cause further problems. Okay.
What are
Another
the normal defense mechanism against which peritonitis body tries to fight peritonitis? क्या
Fight.
defense mechanism?
Fight.
Body कि peritonitis ना हो.
So it releases superoxides which has antimicrobial or antiphagocytic effect, the neutrophils and macrophages in the body, which is hampered by the lactate and bicarbonate and low pH in PD fluid. So it hampers the phagocytic activity of the localized cells.
The biggest important thing is peritoneum is that they are in contact. When you put 2 liters inside it, peritoneum दूर हो जाता है. So it cannot fight back the infection. The contact, it needs to come in contact with the bulk. वो दूर हो जाता है, and you dilute the cytokines and the other protective factors that you are mentioning. That is how you go about it. अब उसको peritonitis हो गई. What you could have taught patient to prevent peritonitis and what she should have done, or what she should do next time.
Sir, retraining session.
Yes. और
Technique.
वो सब हो गया. और उसको क्या बताओ? What should we look out every day?
Urine output.
You should not be constipated.
Hand hygiene and
Hand hygiene, constipation नहीं होना चाहिए. One very simple thing, I mean it looks little theoretical is, initially the fluid color may be clear. The patient has, if the patient has pain, should not wait for all the 3 things. Cloudy fluid, pain and fever. They say I need 2.
Yes, sir.
So if the patient has pain, either it is PD peritonitis or something else. You should always, in a CAPD patient, you should always take it as PD peritonitis unless proved otherwise. So as soon as the patient has a pain, you should send it for cell count and culture. Don't wait for the fluid to turn cloudy. In your patient, they were 10 days were lost.
Yes, sir.
I am sure growth नहीं आएगी. Growth आएगी?
Culture is awaited, but the cell count was 650.
Growth नहीं आएगी. Very unlikely. Growth will only come when you preemptively pick up the sample. Okay. Some people in some centers, what they tell the patient is, even if you are a little bit in doubt, so the bag that you take out, you put it in the refrigerator, and then do the other bag. अब उसमें जरा भी कुछ गड़बड़ है तो उस बैग को भी भेजो. Okay, then how do you collect the sample and how will you proceed to the lab to establish?
Sir, we send the entire pack to the lab.
What the lab will do?
Sir, they will take out either 5 to 10 ml of
Not 5,
50,
10.
10 ml, sir.
Sir, इसमें mathematics है. 10 ml, then
Either we will give it into 2 bottles of aerobic and anaerobic culture, or we can take 50 ml of fluid, centrifuge it at 3000 for 50 minutes, and then probably put it on media.
कैसे सेंट्रीफ्यूज के बाद क्या करो?
Sir, supernatant.
कितना?
We discard the supernatant and then we keep the sediments on the blood
3 to 5 ml of the sediment that you will
on
proceed.
the media.
Yes. फंगल के कौन से मीडिया होते हैं? फंगल कल्चर के लिए, बैक्टीरियल के लिए तो ब्लड अगर और फंगल के कौन से मीडिया होते हैं? शेवरॉट्स और
Sabarot agar is the media for fungal culture.
यूसी फॉर पीपल.
You have to know all this. You can't say that my microbiologist knows.
वो अच्छा नहीं लगता. You are supposed to.
You have to know it.
Whether you do it or not, but you must know the theory. Okay, then you, empirically you will start with a gram positive and a gram negative as you did. Then what you will do? How long will you follow the patient?
Sir, we'll see the improvement, clinical improvement over next 72 days.
72?
3 days, 72 hours. And if there is no improvement after 5 days, we plan to take out the catheter.
Which organisms you can try to keep the catheter? देखो कहना बड़ा आसान होता है, पेशेंट के दिल से पूछो, निकालने के भी पैसे देगा इनको, डलवाने के भी फिर पैसे देगा, and there is only one peritoneum. He has 4 accesses, but only one peritoneum. It's not very easy every time to get in a good position in a CABD. So endeavor should be to save the catheter, but certainly not if the peritonitis is continuing. No, it will be more harmful. किसमें catheter को we can try to save for some time?
Gram negative, tuberculosis.
Tuberculosis, not gram negative. Tuberculosis is a good answer. और किसमें absolutely निकालना है?
Staph, pseudomonas, fungal.
Fungal, absolutely निकालना है. Staph का भी दो चार.
Fungal.
Okay. Now cell count, you did the cell count. Okay. उसमें पॉलीज आ रहे हैं तो क्या सोचोगे, लिम्फो आ रहे हैं तो क्या सोचोगे, यूस्नोज आ रहे हैं तो क्या सोचोगे?
Sir, eosinophils are it could be chemical peritonitis or any helminthic infestation. Sir,
और
lymphocytes.
और किसी चीज से आ सकते हैं यूस्नोफिल्स CAPD बैग?
Allergy at time. Drugs.
Dialysate. Yes.
आइकोडेक्सिन.
Hypotension.
अगर आइकोडेक्सिन यूज कर रहे हो तो अगर यूस्नोफिल मिला हो सकता है पेरिटोनिटिस ना हो. आइकोडेक्सिन कैन ब्रिंग यूस्नोफिल्स इन योर बॉडी बिकॉज़ ऑफ द. ठीक है, याद रखना. पॉलीज और उसका रेशियो देख लो, 50 से ज्यादा है तो इट सजेस्ट अ बैक्टीरियल इन्फेक्शन, है ना? ट्यूबरक्लोसिस वी कैन ट्राई टू कंटिन्यू फॉर अ लॉन्ग टाइम. When will you decide to shift the patient to hemodialysis? What are the criteria to shift the patient to hemodialysis?
During episode of peritonitis.
तो ट्रीट कर रहे हो.
And
इसे कैथेटर रिमूवल.
catheter removal.
हर पेरिटोनिटिस तो हम होपफुली एक्सपेक्ट करते हैं कि रिकवर कर जाएगा पेशेंट ना. आंसर शुड बी आफ्टर कैथ रिमूवल. In the bridge to second PED insertion. What else?
Low transporters.
फिर गलत हो गया. हाई ट्रांसपोर्टर ज्यादा ट्रांसफर करते हैं. तुमने पेट टेस्ट पढ़ा दी थी.
Type 2.
Type
Filtration failure. What else?
The complication of EPS and fine.
Normally we say PD first. What happens down the line to a CAPD patients? आज start किया. अगर if everything is same, if there is no physician bias, if there is no patient bias, if there is no pecuniary involvement, like जैसे insurances don't reimburse CAPD. Is that right? Many insurances don't reimburse CAPD, so patient don't want to do CAPD because they have to pay from pocket. But supposing these things are not there, CAPD is a physiological modality to start. But then what starts going wrong and when?
Sir, patient can require more antihypertensive with time.
क्यों?
When the urine output decreases, eventually requirement of antihypertensive increases.
क्यों होगा अगर तुम कुछ और कर दोगे तो? What will you do? कर दिया. अब 6 महीने के बाद, 8 महीने के बाद, साल के बाद चला गया उसका रेसिडुअल रीनल फंक्शन. नॉर्मली क्या रेशियो रहता है एट द स्टार्ट ऑफ CAPD रेसिडुअल रीनल फंक्शन और CAPD का पेरिटोनियल CAPD कहते हैं ना रेसिडुअल यूरिन और पेरिटोनियल यूरिन. क्या रेशियो रहता है नॉर्मली, इनके कंट्रीब्यूशन क्या रहता है डोज? रफली 80-20 रफली टू स्टार्ट. 3 ml GFR भी अगर पेशेंट का है तो ही कैन प्रोड्यूस अबाउट 0.2 करीब दे देगा वो आपको डोज. As you go down the line, residual functions will go down. So what will you do? You will increase the CAPD dose. The answer is not कि antihypertensive बढ़ा देंगे. Antihypertensive क्यों बढ़ा रहे हो? Because patient volume overloaded हो गया, inadequate हो गया. So you will increase the CAPD dose. And how will you do that?
Sir, we can increase the dose volume or dwell time and the concentration of glucose.
So in your patient, how will you decide to write a prescription and how will you tell? इसको हम CAPD देंगे, इसको NIPD देंगे. You are aware of these terms? NIPD, CAPD, CCPD. पता है आप सबको ये terms? I hope you all are aware of these terms. These are important terms. How will you decide?
Sir, cost wise, if patient is active and likes to travel, we will take the lifestyle of the patient into account.
Weak answer. Anybody?
Solute feeder, the patient is
नहीं नहीं आंसर क्वेश्चन. How will you decide? आज पेशेंट को मैं जा रहा हूँ जनवरी में. Then the patient was initiated on CAPD. He just started in 1.5 into 4 bags. This is not the way to start CAPD. Okay, this is not the way to start CAPD. PET test नहीं किया, so they were empirical. अब आपने कर लिया. Now how will you decide कि हम इसको NIPD करेंगे, इसको CAPD करेंगे, इसको CCPD करेंगे?
Sir, it depends on solute clearance or
तो
ultrafiltration.
कैसे पता लगेगा solute clearance क्या है इसका? How will you know? पेशेंट थोड़ी बताएगा कि मेरा solute clearance ये है. PET test से you will divide high transporter, high average, low average, low. Low average means that the patient does not lose water for a long time. तो solute clearance उसका धीरे धीरे होता है. Glucose dissipation is slow, so the ultrafiltration is also gradual. So they will do very well on CAPD. 6 to 8 hours into 3 exchanges. You may keep the night wet. In patients who are high transporter, they will dissipate their glucose load in 2 hours. So what you should do? You should change the bag after 2 hours. So 2 hours, 3 hours, 2 hours, 3 hours. Best way to do is NIPD. अगर मैनुअली करोगे तो ना पेरिटोनाइटिस होती हुई तो हो जाएगा. but जितनी बारी कनेक्टोलॉजी करोगे उतनी बारी पेरिटोनाइटिस हो. So in high transporters you will do NIPD. APD कह लो, NIPD कह लो, right? That is the basic division. And as the patient progresses ahead, then you will have to add the dose. NIPD की problem ये है कि contact time कम होता है उसमें. So how can you correct that? What can you do for that?
Long dwell. Last long dwell.
Yes, very good. सही बोल रहे थे कुछ.
Daytime dwell.
CCPD डे टाइम 6 आवर का दे दो एक, या मिड आफ्टरनून डुएल दे दो एक उसको, तो वो अपना करता रहेगा. और दादा और बताइए.
No, that is the thing. Basically, transport status. Transport status, high transporter, you need multiple exchanges, high delivered volume of dialysis. In a low transporter, you need longer dwell time and longer contact time. That is the basic. So this is how you decide. And when a patient has peritonitis or any change in this thing or a recent surgery, you can't initiate it on automated on NIPD. You have to go back to manual CPD and then change over to NIPD later on. In children, you cannot give NIPD. Again, you have to give manual corrections. Then you have to also understand that adequacy of dialysis is much more than your KT upon B.
Yes.
There is the patient's nutritional status, anemia status, serum albumin, mental status. All these form adequacy of dialysis. So your one question was left half unanswered. When you are giving your exams again, mentally prepare some answers for yourself. You're sitting, you know कि ये points हैं. Otherwise, you'll keep faltering on your answers. Classify your answers, you'll not miss things. Alright? Most examiners will give you hints. Please listen and also listen to the question before answering. Nothing is more irritating to an examiner when you ask a question and a different thing is answered. Okay. After all, most of your final years, you're going to face your exams soon. And not knowing adequate about CAPD is just not possible. You cannot clear your DNB.
1/3 nephrology है ना.
You have
Transplant,
to know.
hemodialysis, CAPD.
And
Therapeutics में 1/3 है.
can you do CAPD in the type 1 diabetes?
We can.
We can? Sure. 1/3 diabetes. 1/3 type 1 diabetes. 1/3 type 2 diabetes. 1/3 type 3 diabetes. 1/3 type 4 diabetes. 1/3 type 5 diabetes. 1/3 type 6 diabetes. 1/3 type 7 diabetes. 1/3 type 8 diabetes. 1/3 type 9 diabetes. 1/3 type 10 diabetes. 1/3 type 11 diabetes. 1/3 type 12 diabetes. 1/3 type 13 diabetes. 1/3 type 14 diabetes. 1/3 type 15 diabetes. 1/3 type 16 diabetes. 1/3 type 17 diabetes. 1/3 type 18 diabetes. 1/3 type 19 diabetes. 1/3 type 20 diabetes. 1/3 type 21 diabetes. 1/3 type 22 diabetes. 1/3 type 23 diabetes. 1/3 type 24 Sure.
there is hyperglycemia.
Don't give explanation. The answer is
Yes, sir.
can you do CAPD in type 1 diabetic? You are unnecessarily confused. Why can't you? Diabetic and stage renal disease is the same.
See,
This
that
will
is the
examine
catch
it. This is
question. Na?
exactly
Why
what
should you
is
get
going to happen
nervous?
here. Name
Principle तो
three.
same है ना? Principle तो same. Why should you get nervous?
Name 3 significant trials on CAPD.
Sir, Canusa, Admex, and Hong Kong.
Very good. What was the result of Canivus?
Sir, Canusa study was done in 1996 and the reanalysis.
I didn't ask you that.
नहीं बताओ क्या result क्या answer क्या उसका what did it tell us?
Sir, 0.1 decrease in KT by V was associated with rise in risk reduction for mortality.
What did the Adimex study tell?
There was no difference between high or low KT by V in outcomes.
What was the post hoc analysis of the Adimex study?
The significance of residual urine output.
Very good. Absolutely. When they found that why should clearances between 1.7 and 2.1 not matter, they found the very large importance of ultrafiltration and residual urine output. That's why if you have an ultrafiltration of less than 400 ml, your CAPD fails. So 3, 4, 5 important trials you must know. When was it done? Where was it done? What was the reason? What was the study population? And what is the result of that trial? What was Hong Kong?
Hong Kong, sir, it had 3 cohorts, 1.7 to 1.9, 1.9 to 2.1 and 2.1 and higher. All these 3 cohorts had similar renal residual outputs, and it again said there was no difference in outcomes and mortality in all 3 groups.
So as a result, many Western countries where cost is also an issue, sometimes you find CAPD patients being put just on 1 exchange a day, 2 exchange a day, and if the patient is well maintained, they are doing it. How far that is physiological only time will tell.
So nutrition बस 5 मिनट nutrition के बारे में बताओ. How will you establish nutrition in this patient? क्या marker होंगे? How will you know that the patient is not catabolic? He is in neutral nitrogen balance. Nutrition is very important.
BMI sir first, anthropometry.
BMI 2 साल में फर्क आएगा.
Albumin.
120 दिन में फर्क आ जाएगा.
Protein nitrogen excess.
Appearance, PA.
Yes, what is that? What is that? ये बता दो कि sure short pass. Sure short.
Examiner will not ask questions from the chapters you have read.
Sir,
नहीं नहीं ये तो आना है सबको आना है.
Nutrition is very important. Not
PNA,
just
I'm
in
happy to
CAPD.
hear PNA. What is PNA?
Every
उसी के बारे में
CKD
बात
patient you have to know
बता भाई.
nutrition analysis.
वो उसको देख रहा है, वो उसको देख रहा है.
Sir,
साथ में तुम भी गंगाराम क्यों? पता है क्या नाम है तेरा? तू बता देना. PNA क्या है बता.
Sir, जो after dialysis urea
बैठ जा यार, बैठ. बहुत देर. Sit down. You did a good job, but answer थोड़े और sharp होने चाहिए, especially coming from गंगाराम. वहाँ तो इतनी CAPD होती है. अगर तुम कहते कि मैं इधर XYZ से आया था, would not have been more forgiving. Coming from गंगाराम, but I know everybody there inside. अच्छी खासी होती है CAPD. देखियो? गलत तो मत कर.
सर जो क्रेटिनिन और यूरिया अगर बढ़ता है किसी पेशेंट में तो वो 2 कारण से हो सकता है. या तो उसका न्यूट्रिशनल स्टेट अच्छा हो रहा हो या फिर CAPD फेलियर मतलब सॉल्यूट क्लियरेंस.
प्रोटीन नाइट्रोजन अपीयरेंस. मुझे घोल मत पिला. यूरिया क्रेटिन पड़ता है.
Urea generation.
प्रोटीन नाइट्रोजन अपीयरेंस. व्हाट इज NPCR?
normalized
बताओ तो अच्छा लगेगा. I'm not here to show off. I wanted to instigate your brain to read. Normalized protein catabolic rate. We all break proteins. We all break proteins, but we break it in a certain ratio and we remain nitrogen neutral. If we unfortunately face a severe illness, hospitalization, burns, whatever, fever, XYZ, you break more proteins. You become catabolic. कहते हो ना राउंड पे catabolic था. राउंड पे डेली चार्ट देखते हो कितना क्रेटिन डेली देख के कहते हो कि ये कैटाबोलिक है कोई ऐसा फॉर्मूला कि क्रिएटिनिन का राइज देखा आईसीयू में कि यार ये तो कैटाबॉलिक आज फिर डायलिसिस देख लेना। अच्छा, क्या इंपॉर्टेंस है नाइट्रोजन अपीयरेंस की, प्रोटीन नाइट्रोजन अपीयरेंस की, प्रोटीन कैटाबॉलिक रेट की? प्रोटीन पेशेंट को कितना प्रोटीन खाने को बोलते हो? 60? अरे 1.1 गड्ढे में गया, कोई फिगर बताओ ना डाइटिशियन को। 60 ग्राम पकड़ ले, 60 केजी का आदमी को 50 केजी का आदमी को 60 ग्राम प्रोटीन खिला दिया, कितना नाइट्रोजन आएगा 60 ग्राम प्रोटीन से? कभी सोचो ना। अब तुम्हें याद आया क्यों पूछा था मैंने यूरिया का रेशो? जो प्रोटीन आप खाते हो कितनी देर हो रहे हैं यार? अरे बहुत टाइम हो गया है, जल्दी बताओ बस खत्म, इसके बाद बीवी खाना नहीं देगी। बताओ भाई, एक काम कीजिए, लोग ज़्यादा पढ़ाते नहीं, मेरे को थोड़ी चीज़ अच्छी लगती है। कितना नाइट्रोजन आएगा आपके खाने से? एक ग्राम प्रोटीन से कितना नाइट्रोजन निकलेगा? रफली 6 ग्राम प्रोटीन से 1 ग्राम नाइट्रोजन निकलता है। राइट, लिखो नहीं, लिखने का कोई फायदा नहीं, किताबों में रह जाएगा। कितनी किताबें कमरे पे रखी हैं, कितने जर्नल रखे, तुम लोग तो रखी हो सब गूगल में। हमारे टाइम पे तो जवाहरलाल नेहरू यूनिवर्सिटी में भाग के जाना पड़ता था। 93 में जब मैं एम्स में डीएम कर रहा था, सर ने सवाल पूछा तो सीधे लाइब्रेरी, कहीं और कुछ था ही नहीं, गूगल था ही, गूगल बाबा पैदा ही नहीं हुए थे। यू आर इन अ वेरी गुड टाइम जोन, सब चीज गूगल पे। अभी मैं बोल रहा हूँ, चेक कर लो कि कितना गलत बता रहा है, राइट? सो यू विल बी एबल टू कैलकुलेट नाइट्रोजन, राइट? एंड दैट चेंज ऑफ नाइट्रोजन, नाइट्रोजन कहाँ से निकलेगा बॉडी से? मोस्टली यूरिया, फॉर सेक ऑफ कैलकुलेशन वी से मोस्टली यूरिया। स्टूल से निकलेगा और यूरिन से निकलेगा, स्वेट से तो ना के बराबर निकलेगा। स्टूल का एक फिक्स फॉर्मूला है 0.032 करके कुछ ऐसे ही है, और 8 मिलीकुलेट पोटेशियम और 5-6 मिलीकुलेट स्टूल से निकलता है, अनलेस अनटिल किसी को डायरिया हो रहा। एंड वी आर टॉकिंग इन स्टेशनरी पेशेंट्स, मतलब जो
सेडेंटरी
मतलब जो न्यूट्रल है, नाइट्रोजन न्यूट्रल है, कैटाबॉलिक नहीं है कि डायरिया नहीं हो रहा, आग नहीं लगी, ये नहीं हो, वो नहीं हो। सो नाउ यू विल measure the urine, you will measure the urine urea, that will tell you the amount of nitrogen coming out, and you have the patient diary, कितना भाई दाल खाई, कितना वो खाया, कितना वो खाया। एक दाल में 30 ग्राम में 7 ग्राम प्रोटीन, एक अंडे में 7 ग्राम प्रोटीन। So if you are smart and if you have told the patient कि सब लिख के ला बेटा 3 दिन का, you will know the amount of protein that has gone in his body, correct? And by measuring the urine, you will know the urine urea nitrogen. स्टूल का एक फिक्स फॉर्मूला, दोनों को ऐड कर लो, and if they equate, patient is in normal protein, is not breaking protein. CMPD में you also add the bag, ultrafilter, correct? CMPD का ये advantage, you add the urine, residual urine, you add the urine, ultrafilter, and you calculate the urea, and you see the ratio. If it is constant, the patient is not well balanced. चले? अच्छा, okay, चलो, good, best of luck.